Okay, day 2 at DDW. And the first thing we need to discuss really is the weather. I mean, come on, San Diego. It's May. It's terrible. Better than this in Edinburgh. Okay, now we got that out of the way. We're going to discuss fatigue and sleep, and then we're going to move on to talk about management of IBD, obesity, and a couple of other things. Elsa Hart started this morning with a masterclass in fatigue in inflammatory bowel disease, how to assess, how to manage, talking about sleep with insomnia or fatigue with insomnia. And in fact, we went into more detail about that later on in the day with a very neat intervention from Psychology Service in Dartmouth using CBTI specifically for insomnia and showing great interventions there. More than sleep hygiene, CBT seems to be a great intervention for insomnia. Elsa then went on to talk about fatigue without insomnia and explaining how that's a much more difficult nut to crack. Making sure you've done through your assessment all the screening for correctable causes, of course, also looking for comorbid conditions, particularly depression. And on that, there was then some very useful and practical advice on choice of antidepressants with a particular focus on mirtazapine, because mirtazapine is good for inducing sleep. So see previous if you've got fatigue with insomnia, but also a great antidepressant. And then for truly refractory fatigue without insomnia, the use of modafinil, a wakefulness agent acting through dopaminergic pathways that she and Callum Moulton have already published the first 70-odd patients that they've treated at St. Mark's with great success. Approved through the Maudsley Institute of Psychiatry for use in refractory fatigue. So something to keep an eye on there for sure. There was one more thing on fatigue today, and that was a trial presented by a group from Erasmus, where in fact they were looking at a probiotic. It's a big RCT, 50 patients in each arm, but showing no difference between the probiotic and the placebo. However, what it did show was a staggering response to placebo, as well as, of course, with the active compound, suggesting that there is more at play with fatigue here, and it's careful study of the factors, but also there are learnings from this. There may also be some rationale for revisiting the results from the high-dose thiamine crossover study. I've said elsewhere, I'm not a big believer in high-dose thiamine, and I do just wonder if that's worth revisiting from a statistical standpoint with that in mind. And in fact, there was one more thing about fatigue today, or sleep at least. Robert Hurton, who's been really pioneering the use of wearable data in IBD to predict flare, having published a very neat study in gastroenterology recently looking at heart rate variability, has now been looking in the same cohort at sleep and the impact of just symptomatic activity for IBD, not really impacting on measured sleep. Inflammatory activity, yes, showing an impact on sleep. As we would expect, really, the differences aren't huge, but they're statistically significant. I think it was interesting to see how the sleep tracking can then be fitted in around this more passive measurement of IBD activity that I'm so keen on, as you know. So a few other good highlights today. Ryan Ungaro actually kicked off the day talking about mild Crohn's disease, definitions and management, and presenting a sort of really pragmatic approach. You know, probably 20 to 30, maybe up to 40% of patients will present with mild disease activity and indications of mild severity. And at least half, probably more than 50%, will maintain that mild phenotype throughout. But there is a significant minority who will progress to moderate or severe disease, highlighting the importance of continuing to monitoring, but not being afraid to just induce with budesonide or a course of prednisolone or enteral nutrition, and then maintaining without any therapy at all in Crohn's disease, but keeping going with the monitoring. David Rubin really gave an absolute masterclass in treatment strategies for IBD. Way too much to go into here, and I'll go into it in some more detail. I've covered it at length in the edition of Substack today I'm writing, but I'll come back with a more detailed look on that. Ed Loftus talked about obesity and IBD. Now, this is a really hot topic. We know that we're seeing more IBD patients living with overweight and obesity. We know that there is some data supporting that that is associated with worse outcomes, particularly when you look at visceral adiposity rather than just at a raw indices of BMI. And then also looking on to look at the impacts of bariatric surgery in terms of improving outcomes, looking at de novo IBD after bariatric surgery and at a population scale, showing that that might actually be reduced overall. And then, of course, moving on to look at what we have been hearing a lot about more recently, which is the use of the GLP-1 receptor drugs on patients with IBD living with obesity. And recently we have heard that Eli Lilly, the manufacturer of Mounjaro, which is clearly the leading GLP-1 drug at the moment on the market, they are now going ahead with combo studies of Mounjaro plus mirikizumab in both ulcerative colitis and Crohn's disease. But it was clearly the word of choice. We had Mounjaro and mirikizumab there. We had modafinil earlier and mirtazapine, the 4 M's of IBD therapy. Also this morning, Harry Sokol gave a brilliant talk on the microbiome and IBD, reviewing the literature, where we're at, its impact and its role, and then specifically looking at interventions, discussing why we need to move beyond FMT, why it can never be truly scalable and standardizable enough to be the treatment that we need for our IBD patients. But what was really heartening from that talk was to hear a couple of stories, both Japanese story with the 17 bacteria as a group that promote Tregs that is now moving into phase 2 testing, and also how the F. Prow story, the Faecalibacterium paranoiaceae story, is also now moving into phase 2 testing. Great to see microbiome finally going truly from patient to the bench back to the bedside again. And hopefully we will see microbiome therapeutics coming into the clinic. Harry presented this nice model where we would use our more potent immunomodulatory, immunosuppression targeted therapies to induce remission, and then would be using microbiome therapies perhaps to maintain remission. I suspect it'll be more nuanced than that. I suspect we will be packing in together for different people a combination of induction agents, maintenance targeted therapies. We know that we have some like the P19s and vedolizumab that offer a very excellent persistence and safety, but adding in on top of that combination drug plus microbiome therapy to get people well for the long term. We had some AI stuff today. We had a new scoring system for Crohn's disease colonoscopy. We had session at the end of the day looking at other psychosocial variables, looking at yoga. Very nice study from India there, looking at yoga. IBD Rise, a medical student from Stanford presenting this program of mentoring an adolescent, showing how that would help. And we had a huge number of posters today covering different monitoring and strategies and a lot of drug therapy outcomes, etc. presented there. So that's a wrap from day 2. Tomorrow, we're moving from the side halls into the main ballroom, room 20. That means we've got major therapeutic trials being released. Its focus is going to be firmly on the TL1A drugs, and also some post-hoc analysis, as one would expect still from the P19s and other studies. I'll be coming back with more highlights from that tomorrow. Until then, enjoy the evening, and please, San Diego, sort the weather out.